Good morning, everyone, and welcome to the October meeting of the Group Insurance Commission. Beautiful day here in the Massachusetts-Boston area. So happy fall, and hope everybody who is listening and with us today is starting off their day great. I'm Valerie Sullivan. I am chair of the Group Insurance Commission, and I am joined by an esteemed board. So I have with me Bobby Kaplan, Vice Chair. I have Dana Sullivan, who represents A&F. I have Rebecca Butler, who represents DOI. I have with me Eileen McEnany, Jane Edmonds, Jason Silva, Gerzino Garad, Kristen Pepin, Tamara Davis, Martin Curley, Toby Schote, Anna Sinenko, Dana, I mentioned, I'm sorry, it's Dean Robinson. And then has Catherine West joined? She may
Yes,
be.
good morning.
Yes.
She has joined us as well. So we have a full house today of commissioners, and I'm thrilled to see everybody here. At this point, let me turn over the meeting to Matt Vino, who will go through our agenda for the day. Hi, Matt.
Good morning, Madam Chair. Good morning, members of the Commission. It's terrific to see you all virtually this morning on a beautiful October day. Today, if we can go to the agenda slide, we are meeting to follow up on the discussion we had in September when we shared our current budget situation and our deficiency. And we proposed some potential paths forward as it relates to GLP-1s and other steps that we can take to close that deficiency. And we gathered some feedback and questions from the Commission. We've taken that all back and returned today to update the Commission on two cost savings initiatives that we will be implementing for January 1st, 2026. So look forward to the discussion. Madam Chair, back to you.
So thanks, Matt. Definitely important to discuss the plan that you have along with the staff to drive some cost reductions and try to stave our cost curve, given the challenges to budget that are real and pressing on our state. At this point, I will entertain a motion to approve our minutes, not from June, but from September. So that's not correct on the slide that you have in front of us. So thanks for sending those out. Do I have a motion to approve?
So moved.
So Bobby,
Second.
thank you. And second, Toby. So I am going to ask Andrew to roll call. I am an aye. Andrew.
Thank you, Chair. Vice Chair Kaplan.
Aye.
Commission Designee Sullivan.
Aye.
Designee Butler.
Aye.
Commissioner Choate.
Approved.
Commissioner Curley.
Aye.
Thank you. Commissioner Davis.
She's on mute. Keep moving and then come back.
Tomorrow I'll come back. Commissioner Edmonds.
Aye.
Commissioner Garan.
Yes.
Commissioner McEnany. She is driving. She said she may not be able to speak. Commissioner Pepin.
Aye.
Commissioner Robinson.
Aye.
Commissioner Rodriguez.
Yes.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Aye.
Commissioner West.
Yes.
And let's go back. Commissioner Davis?
Yes, sorry, I was on mute.
No
Yeah,
problem.
I abstained since I was absent.
Okay.
Thank you.
And Commissioner McEnany, can you hear us? The motion is approved with everyone voting.
All right. Thank you, Andrew. And I may have missed letting you all know that Melissa Murphy Rodriguez is here as well. So hello. Okay, we've got that vote put forth and approved. So let's keep moving on the meat of the agenda.
Thank you, Madam Chair. I'll start with a brief recap of our Executive Director's report. I won't read it in its entirety here, but just to highlight a few things. First of all, we are thrilled to be able to welcome our new CFO, Jennifer Hewitt, to the GIC team. Jennifer joins our staff with a wealth of experience and knowledge from over 30 years in public service. Jennifer began her career as a research analyst in the Massachusetts legislature and went on to hold several key roles in the administration, in the Executive Office of Health and Human Services, as well as administration of finance. Following that, she had a decade of experience working at the municipal level, most recently as Assistant Town Administrator and Finance Director for the town of Belmont. And before that was Budget Officer for the town of Lexington. So I hope you can see a resume really tailor-made for the issues and challenges that we face at the GIC. Jennifer has made an impact from day one. And she's only been here just a few weeks. So we're thrilled to have her and hope you'll join me in welcoming Jennifer.
Yeah, that's great. Thank you, Matt, and welcome, Jennifer. And I know Emily has put in an enormous amount of work and the team in general in onboarding her. So thank you and welcome.
Yeah, and filling in for Jennifer, filling in for the vacant role before we were able to hire on Jennifer. So just a big shout out to Emily Williams, our Chief of Staff, for keeping a bunch of things together. She's the glue in many respects. So thank you, Emily. The second item, just a quick item on the legislative front. Just two items, and one of them a correction, so apologies. Number one is that the veto that we have discussed specifically at our last commission meeting, $27.5 million of our healthcare claims line, with a request from the governor to consider eliminating coverage for GLP-1s for weight loss mid-year. That veto still stands. The legislature has not taken up that veto. So just number one update. The second update is regarding the statutory authority to make mid-year changes that accompany that veto. That was filed in a separate bill. In my ED report, I noted that had already been taken up by the House this week. That was actually a different supplemental funding bill. So the bill that includes the language that would allow us to make that change is still pending, and there's been no action on it in the legislature. So just wanted to give that feedback. Really no changes on the legislative front there. On the communications front, we continue to lean into the tools that we've built through our multi-year modernization effort. And we're also at the same time beginning to unwind some of the legacy online capabilities that we had before we were able to launch the GIC member portal, My GIC link. So the latest phase here is the discontinuation of what we call the GIC online forms. A member can go to our website, download a form, submit an inquiry to us. We have it in a digital form and staff can handle it as a case, but that has now become really duplicative and unnecessary given the similar tools that we have through the portal. So that allows us to terminate a contract, to not renew a contract with DocuSign that has stood that up. We will achieve some savings by having done that, which is good news. We will be directing all members who wish to interact with us online to use the My GIC link tool. So this means that those forms will no longer be an option on our website effective this December. I will note, however, that members will still be able to submit paper forms through the mail. We do know that not all of our members have the fluency or comfort to interact with us through online tools. So they can always continue to call us and submit paper forms through the mail. I will just note on this one too, we've been working closely with ANFIT, our colleagues there, and we have a significant kind of change management communication strategy directed primarily at our GIC coordinators, as well as members, but really it's the coordinators that are key to making this change. So we're doing a lot of work with those who represent us at the agencies and municipalities that are out there. There have been a number of them that, a small number and a decreasing number, that have continued to sort of use this legacy form. And we really want to drive all of our traffic online through the member portal. So that is my executive director's report. Happy to take questions.
Matt, I just have a question regarding the DocuSign contract. Like, how much of a savings will that be?
I don't have that figure handy, but we're happy to circle back with the commission with that figure.
Okay, thanks.
Yep.
All right, let's keep moving. Thanks, Matt.
Okay, so we'll move on to the meat of today's agenda with our cost savings update. We can move right to the next slide. So I'll be joined today by Andrew Stern. I'll be presenting. Andrew will be here in support to clarify or correct anything I say that's not correct. And also by our colleagues at Willis Towers Watson, Jeff Levenshires. They have all been a key part of this effort, a joint effort between staff and WTW. But forgive me, this will be a lot of me presenting, but I'm happy to pause for questions as we go through. So let's start by just briefly revisiting the issue we're trying to address as we presented to you back in September as a result of policy decisions made in the legislature and by the governor in crafting the FY26 budget. We began the year with a $77 million deficiency. An element of that, of course, has related to GLP-1 coverage, as we've discussed. But as I noted, that veto has not yet been overridden, and the supplemental budget language that gives us the authority to make those changes was not passed. So we wanted to go back to the drawing board, evaluate what tools we have, which are limited, to make changes in the middle of the year so that we could at least attempt to close the gap, specifically on the GLP-1 portion of that deficiency. I do just want to note as an aside here, a follow-up at our September commission meeting. I think it was Commissioner West who asked what portion of our FY25 deficiency, that was $237 million. We had to have a supplemental for that. What portion of that was attributed to the growth in GLP-1 spend for weight loss? Our budget director and CFO have run some numbers there. And I can tell you that of that 237 million, 61 million was accounted for by the growth in GLP-1 drugs for weight loss. So roughly a quarter of our of our deficiency for last year was driven by GLP-1s. So clearly, as we've been saying and acknowledging, the impact of these drugs on our budget really must be addressed, while we also balance the impacts on the lives of our members who use them. So just a quick reminder of why we're here today. So on the next slide, again, this next slide will look familiar to you. Again, taken from our September meeting, where we laid out our early evaluation of steps that we could take mid-year to contain the cost of our GLP-1 coverage. And as we explained in September, we're looking for a solution that can address the deficiency, can be consistent with our statute and what we can do mid-year, and also the constraints of our contract with CVS. So I've highlighted red here the box that captures where we were already starting to zero in on a solution that we could implement by working with what we call, what kind of term of art in the industry is a center of excellence comprehensive weight management program that would assist members with their weight management and require participation in a program in order to gain or maintain access to GLP-1s. So that is the path that we've chosen and that we're here to talk you through today. Earlier this week, I signed an agreement with one of these vendors that we felt confident, based on our due diligence, is best positioned to help us meet our objectives. So today we want to talk a little bit about the process that led us there and about the program that we'll be implementing starting on January 1st of 2026. So before I move to the next slide, I just want to say a quick word about the concept of a center of excellence in healthcare specifically. You may have heard the term, but what is it exactly? So simply put, a center of excellence is a specialized healthcare delivery provider that delivers high-quality, patient-centered care in a specific area of medical expertise. So where I think folks commonly see them is in the area of hip and knee replacements, where you have the option for an employer base subscribers to get those services at any network provider. However, if we can identify a particular provider who has a high degree of excellence and success, does high volume in these services, and really has worked out how to do it the best, and can manage the cost through some innovative payments, it provides a real solution to a health sponsor like the GIC, where we have either variations in clinical practice in the network of providers, and we just need to be able to ensure that the care is delivered in an efficient and cost-effective manner. So this is the model of program that we're moving forward with. As you can imagine, the marketplace of center of excellence vendors for obesity is very crowded, with many vendors offering a wide variety of solutions. But the core approach is generally the same. And we'll talk a little bit more about it as it relates to the vendor we've chosen. But they employ a team of clinicians that are specifically trained in obesity treatment, and they work with patients and the patient's doctors to develop an individualized treatment plan for each individual member. And it's this team of clinicians that becomes the exclusive channel through which patients can gain access or maintain access to GLP-1s for weight loss. So just a brief thumbnail of what a center of excellence is and why we've moved in this direction. On the next slide, I'm going to pause and take a drink. All right, so let me just say briefly a word about the team that's worked on this. As I mentioned earlier, we've been working closely with the team at WTW, as we do on all things of real import for us. And this, as is often the case at the GIC, on the staff side, has involved a number of units: the legal unit, our data analytics unit, our vendor management unit, as well as others. And so that group has, working with the leadership team, put together a series of goals to guide our decisions here. And we lay them out here on this slide. We needed a vendor to get started with us as soon as possible so that we could achieve maximum savings in this fiscal year, close that deficiency. So we needed a vendor with a simplified implementation schedule. And we were really targeting January 1st, as that made the most sense for us. We tend to see changes like adjustments to formulary on the January 1st date. So we wanted to try to make this as predictable as we possibly can, and on the kind of in the normal sequence of us doing things so that our members could be clear about it. We also needed a vendor with experience working with large clients. We cover 467,000 members, so they need to have the capabilities and the bandwidth and the staff depth to do that. We specifically evaluated their ability to also work with a diverse population. That, of course, very important to our meeting the needs of all of our members with a health equity lens. We also needed a vendor, of course, that would provide excellent service to our members so that we can really maximize the likelihood that our members will be successful in achieving and maintaining their weight loss. So guided by these goals, we chose, you'll see at the bottom, to closely evaluate 4 of the multitude of weight management vendors. And we selected these 4 because they are already a close part of the CVS ecosystem of partners. So it gives us the confidence, since CVS is our PBM, that we can reduce the risk of any hiccups with a vendor with which CVS is not as engaged as they are here. So on the next slide, happy to keep plowing forward, happy to take questions now or at the end. A little bit about the process here, just one slide, but we wanted to give you a sense of how we approach this. The GIC and WTW team conducted interviews with each vendor. The team closely evaluated a variety of characteristics driven by these evaluation criteria using a scorecard. So the way we would typically do this as part of a procurement evaluation, scoring each vendor based on experience, financial arrangements and performance guarantees, the level of service they're able to provide our members. And based on the criteria, the interviews, the scorecard, the team determined that Vita Health, the vendor that goes by that name, is the best path forward for us to maintain coverage for weight loss, but also try to manage to our budget as best we can. So that was the process. Got a couple more slides. The next is some specific information, actually the next 2, some specific information about Vita Health. So starting on January 1st, our vendor partner Vita will become the sole prescriber for GLP-1s for obesity. This will provide members with support for weight loss. They develop comprehensive, individualized treatment plans. As I've said, those are created by a team of physicians, endocrinologists, dietitians, mental health therapists, a care navigator, a real multidisciplinary team, all with specific training in weight loss and weight management. And they bring to the table, importantly, the cultural competency necessary to serve our diverse membership. So they'll provide the members, as I said, a variety of tools and resources to assist them. For us, from a financial perspective, we are anticipating that this partnership will deliver annualized savings of $30 million. So applying that to the second 6 months of this plan year, we anticipate a $15 million savings to us. I will note here, and I mentioned it in the slide, but we'll address it again on the next slide. We do have performance guarantees that are part of this arrangement with VITA. They're linked to operational metrics, clinical metrics, positive clinical outcomes, as well as savings to the GIC. So the vendor has significant portions of their administrative fee here at risk if they fail to meet the benchmarks that we've set for them. I really want to thank the team for, particularly the strategy and data analytics team, for giving that a great deal of thought. So under VITA, members who are currently prescribed GLP-1s for weight loss will maintain access to GLP-1s if it is clinically appropriate, and they continue to stay engaged in the program, a pretty rigorous program offered by VITA. And therefore, those members who don't engage to the requirements of the program may lose access to GLP-1s, but they will continue to have the resources of support beyond that for other treatments managed by VITA. So on the next slide, this is the last one on VITA. Then I'll get to the second element of our deficiency plan here. We want to illustrate a bit about the member's experience and what the member can expect by participating in VITA. So we have developed and will continue to develop, actually, as part of the implementation, a comprehensive communications plan. We'll be doing direct member outreach to GIC members that are currently on GLP-1s, explain to them the change that is happening and the need for them to enroll in this comprehensive program to maintain coverage. As a bit of an aside, although it's an important aside, if a member has not yet enrolled and engaged with VITA and they go to fill their prescription at the pharmacy, it will be denied at the pharmacy because it was not prescribed by a VITA provider. The member will be provided at the point of sale instructions to contact VITA so that they can get that process underway. Our hope is that our prior communications and outreach efforts will minimize this kind of a circumstance. But I do want to note that that is contemplated, and we provide a path and support for members if they end up in this situation. So once enrolled in VITA, as you'll see here, members will complete an initial assessment and select a VITA provider. They will attend sessions with their selected provider, who will order labs, collect medical records, and really start to put together that individualized care plan. Members will also have the opportunity to engage in app-based content and tools to strengthen their skills around weight loss, to track progress, and to connect with other VITA providers for follow-up as needed. So some really good member-facing tools. If a member is prescribed a GLP-1 for weight loss through VITA, it will be a 30-day prescription, and and that would be, that's implemented as a mechanism to ensure that the member continues to be engaged with VITA beyond just the prescription to take all the other necessary steps to maintain weight loss. So engaged participants, as you'll see here, are expected to regularly record their weight. They log their food intake daily. They attend scheduled visits with a registered dietitian or a physician. They complete self-directed cognitive behavioral therapy lessons as part of that personalized plan. And this is, I think, important to note. A few of you have already asked me questions about this. With the members' permission, the VITA providers will collaborate with the members' primary care provider and any specialists involved in their care. That will be an important part of the success here, frankly. So we do hope that members give that permission. That will allow providers to share plan notes, to share progress updates, and discuss in a team basis clinical recommendations for that member. One more point, Bobby, and then I'll take your question. Once patients reach their therapeutic goal, reach their weight loss goal, and they're stable, then VITA initiates essentially a longer-term clinical plan around maintenance. And this may include remaining on GLP-1s if that is determined to be necessary, or moving on to other medications that are not GLP-1s, or possibly discontinuing pharmacotherapy through GLP-1s entirely. But all of this, I want to emphasize, is driven by the specific members' progress and their level of engagement with the plan. We want to make sure that they have the full range of supports beyond just GLP-1s to maintain weight loss. I will pause for a question from Bobby and this concludes the VITA presentation. So any questions on VITA, I'm happy to take them now before I move on to the other item.
Okay. Thanks, Matt. I have a few questions. So at the so first of all, what does that mean by rigorous program? Are you talking about the sort of keeping track that people have to enter into, let's say, a database, their food intake and what they're eating, the amount, how many ounces of, whatever, chicken that they're eating? Is it that sort of detailed? They have to take their weight, they have to weigh in every day or something? And what happens when can they just be enrolled in VITA, let's say for existing, for our members who currently are on GLP-1 drugs, when they enroll in VITA, let's say they enroll and then they go to CVS to pick up their prescription, is just by virtue of enrolling allow them to get their prescription, or do they have to go through a whole series of, let's say, meetings? And at what point is the primary care provider or whoever is currently prescribing the GLP-1 drugs involved? And does the member have to provide access to their medical records to VITA? And if they do, how would those medical records be protected? How would the data be, protected? What is VITA doing with those records? What happens with that? And what if they miss? What if the member misses one item, right? What if they don't go to their therapy meetings, or Do you have any idea like how long this process will take? Like how many hours a week is involved in engaging with Vita? And what happens if you mess up and forget a meeting, or you forget to do something, or life happens and you don't record your weight for a few days? Does that mean you know, and are the drugs only going to be prescribed like for 30 days period? You know, no 60 or 90 days, just 30 days ongoing. And if you mess up, you don't get it the following month. I know it's a lot of questions,
That's
so
a
I
number of questions,
apologize.
and I'll do my best to get through some of those. I would say I'll let Andrew speak to the sharing of medical records and the protections that are put in place. Those are all strictly governed by federal and state law that we are ensuring to be compliant with. My understanding of look, I think a lot of these questions, Bobby, are already on our minds. We have some information on them based on our due diligence to date. But as we move into implementation, these are a lot of the questions that we will explore with them and create greater detail. In terms of your question about, your other question was 30-day prescriptions. Mm-hmm. So that is the model. And the intent there is to use that as essentially an accountability mechanism with the member, that you need to stay engaged in the program to maintain access to the very expensive drug. And the reason for that is evidence suggests that you're most likely to be successful with the drug when you do all these other things, diet, exercise, to the degree that you're able. So we want to make sure that if we're going to pay for this drug for you, that you're doing your part as part of that comprehensive plan. It will increase the likelihood of success for you and for the GIC to make sure that we get the value of the significant investment. On your question about, you know, if someone misses a meeting or you know, just doesn't upload their meal data on one particular day, are they just going to be dropped off? Look, we and Vita have every incentive to keep members engaged. So we don't want to we're not putting in place a set of hurdles that everyone needs to cross, and if you miss one, you're done. That's not our intent, and it's not the way Vita operates, and it's not, frankly, aligned with their financial incentives. They get paid by participating member per month. So if a member drops off, they don't get paid. So their incentive is to keep members engaged. However, keep them engaged in a way that meets the program criteria. So we'll be exploring all of these issues in more detail over the implementation plan. Andrew, please add what you'd like there.
Sure. Couple of things. First, members who are currently on a GLP-1, when the program starts, we built in a transition period. So no one's going to get thrown off on January 1st. There's a 90-day transition, but you have to participate in the program. It's not as draconian as you think, Commissioner Kaplan. It is, but it does have there has to be minimal engagement every month, or they will not get that prescription filled, which are for 30 days for that very reason. In terms of medical records, these are providers, they're bound by HIPAA. We have a business associate agreement with CVS that flows through to them. So in terms of data that we are providing or is going back and forth, it's all protected under the HIPAA standards. And we want people to be providing their medical records because in order to do clinically appropriate care, Vita is going to have their records, and they're going to be meeting with people and going through their clinical picture at inception of their relationship. There's going to be labs done, things like that. And we want them to share them with their primary care physicians because we want coordinated care. So I'm hoping that members who sign up will not have any problem with allowing the clinical team at Vita to communicate with their primary care physicians. And those records, of course, are protected just like they were at their own doctor's office. I hope that answers those questions.
Well, thank you, Andrew. I have another one. When you talk about, let's say someone goes to a particular, lab to get their blood work done, regularly, right? So will people still be going to wherever they go for tests or whatever? And then that information will be sent to Vita and their primary care, let's say, or the doctor who's prescribing or who was formerly prescribing the GLP ones. Like, is there an expectation that relationship between let's just say the primary care provider and all the, physicians at Vita are going to be in regular communication?
I think that's the expectation. Like if members are not going to be directed to a particular lab or anything like that, they'll be uploading or providing access to the laboratory results, which, as you know, when you go to have lab work done, you can direct it to go wherever you want. So you can have it go to your PCP as well as Vita. And my understanding is they'll share that information with the primary care if it didn't go directly to the primary care physician. Again, it's a collaborative approach. They're not, members have other comorbidities and other issues that they're being treated for. And this program does not want to stand in the way of a member's treatment for other things. It is just a center of excellence for weight management. And Vita has been in the business for since 2014. They started in diabetes care and management. One of their goals is to keep members from becoming diabetic. It's a very fulsome program.
Thank you. Do you know, will there be like a single point of contact, let's say, from the member to Vita? Or are they going to have like
they'll have a
like
team that's assigned. When they join, they get an assigned team. So they'll have, and they have a care manager who will help coordinate if they have other issues that need to be coordinated. So yes, they get their own particular person that they are dealing with, or more than one person that you're dealing with.
Okay, thank you. Thanks.
Bobby, we're going to move on to Catherine and then to Jane. Hi, Catherine.
Good morning. Thank you. Thank you, Chair. So I have one question for you, Matt and Andrew. I'm wondering if we can talk about metrics and reporting. I think it'd be really important for us to learn as a commission and for the GIC team as well to see where we're learning and where there are opportunities for improvement. And for me, there's probably three areas. One around engagement, which Bobby raised, and which the vice chair raised, and where are members engaging and where are we losing members potentially. Second, around outcomes such as weight loss, clinical control, and improved quality of life. And I would be interested to hear more how improved quality of life is being measured. And third, around the financials and the financial savings and total cost of care. And across the metrics, it would, of course, be, I think, most helpful if metrics can be stratified by race, ethnicity, age, and geography as well, so that we get a sense of any variations of our membership across those different areas. And I recognize that reporting takes time and there won't be data immediately, but I'm wondering if we can include the opportunity for regular reporting to certainly the GIC team and then to the commission, perhaps on a quarterly basis, so that we can keep a pulse on how the program is rolling out and also look for opportunities for continued learning and improvement.
Yeah,
I'm sorry.
I'm sorry, go ahead, Andrew.
We built reporting is built into the contract. I have to give Jiang Su and Laura Makashima a lot of credit for going through the PGs with a fine-tooth comb to make sure that they were meaningful. There's clinically based ones. And they're measured out. I think the first measurement starts like at 6 months out. They include, engagement. They include net promoter scores as in operational things, where some of the things you asked about, but they also include, and there's 100% fees at risk under this contract. A1C improvement, weight loss improvement. There's pre-diabetes tracking. I would be happy to send you the contract in the future so you can see the reporting requirements. But we'll be getting regular reporting from them. Obviously, a lot of this isn't going to happen until you're out about a year to be able to see how the population has improved, what the demographics look like, what the improvements look like. And we can share that back to the commission as the program goes on.
Yeah, and I would just say a couple of things. You see here on this slide, actually on the right, and the blue box, these are the, as I think you're suggesting, Catherine, these are the domains, primary domains where we see their performance guarantees. So on the total cost of care, we have an ROI based on our investment. What sort of savings do we see that we're going to achieve? And again, they're at risk if they don't meet those. Sustained weight loss benchmarks of 7 to 10%. The clinical controls, as Andrew noted, with monitoring of blood sugar levels with A1C. So the improved quality of life. So as I understand it, and there may be other members of the team or Jeff Levenshires who can speak on this, but there is a validated, very established a tool to measure. It's essentially an individual's perception of their well-being and satisfaction with life, and how specifically it is influenced by their health status and their treatment. There are a number of domains as part of this tool. It's physical well-being, like function and mobility and pain, sleep and energy levels. It's psychological well-being, mood and emotional state, social well-being, a sense of their social interactions with relationships and at work, and spiritual well-being. So it's actually a tool that's been out there for a number of years and there are 15 different domains of measurement as I understand it, but we're happy to provide some more detail on that.
Okay, thank you, Matt. That's good to hear, and I'm glad that it's a validated tool. And thank you, Andrew. I would be interested in the metrics and just want to lift up the demographics, not only overall membership, but any stratification that can be done for these measures across race, ethnicity, age, and geography. I think will be really helpful.
Yeah, we're going to lean as heavily as we can into that. I will note on that front that there's actually been some movement of late that I think will really benefit us. We've been prodding and prompting policymakers to provide greater detail on the data standards that can allow us to stratify by all of those factors that you note in a way that is consistent across the marketplace, so that we're not each in our silo doing these things differently. That actually is on a pretty aggressive timeline now, and my hope is that it'll help. We have in place a number of efforts in our own silo because we couldn't wait for that. So we do look forward to applying that with Vita Health. I will say for Vita, the social determinants of health is their approach to this is one of the reasons that we chose this vendor. They take this into full consideration. They have members screened for social risk factors such as social isolation, food insecurity, and those are weaved into the care plan so that it's realistic and sustainable. Vita, since we're talking about diet and nutrition, we know that there's variation there from a cultural standpoint. And so, as the dietitians on the team are providing guidance to those members, we want to make sure that those dietary options are done through a culturally aware lens, right? They've got a bilingual staff team, and so we've evaluated that. So we're gonna be leaning into this quite a bit as we go forward. It's an important part of how we want to understand how this impacts our members. Because we know, as Margaret said at our meeting in September, that a significant portion of our membership on these drugs is likely from communities of color. Thank you, Catherine.
Jane, I know
Thank
your
you.
hand was up after Catherine's, and then Toby, and then Eileen. I think I got that.
Thank you, Madam Chair. I guess I have several concerns. Yeah, I recognize, first of all, that this is a tough issue for Matt and the team, and appreciate the time that's gone into this. And I also recognize that Vita's role can be valuable, but my concern is that it can't replace medical judgment. And what I worry about is that when a doctor is prescribing GLP-1 drugs, that's a clinical decision made in good faith. And I would hope that anything that we do would ensure that there's a process that supports and it doesn't undermine that trust. Anecdotally, when I've had a chance to talk with different people in the community, both patients and other medical providers, that's the kind of a message that I hear. So I think we have to be, again, clear that when you have a patient, and any patient, if you have a licensed physician prescribing that drug, that decision comes to me, in my mind, comes after very careful medical evaluation. It's not convenience or vanity or guesswork. And then these medications are changing so much, so you can't simply just, change somebody's GLP drug to another and not expect that there's going to be a medical consequence to that patient, because many patients have shared with me anyway that they are successful on one drug and not successful on another drug. So there's so much complexity attached to this issue. And the bottom line is that if you talk to, I think, any good physician, they'll tell you that these medications save lives. And that includes diabetes. One of your first slides, Matt, I think shows that the governor's decision to cut the GLP drugs, but then there's an exception for diabetes. In some ways, that feels to me like an inconsistency, a medical inconsistency, because it's very clear that GLP drugs do help patients with diabetes. And so that's what the evidence shows. That's what the data shows. So I guess I'm being a little bit long-winded here, but how do we respond to issues around perception and process? How do we respond to people who will say that we're second-guessing professional judgment? So this is a tough issue because I keep on saying to myself, my gosh, we'd never tell an oncologist that their cancer drug decision must be reviewed by a wellness vendor. And so, you know, for me, why is obesity different? And I hope that we, you know, think hard about coming up with solutions. And then my final question is, again, one that we've talked about forever, is what we're doing to try to just lower the cost of drugs, period. Anyway, I'll end there. But I do hope that we think hard about the implications of our actions in terms of perception and process.
Yeah, thank you for that, Commissioner. A couple of things I'll say about that. And so I think the thing to know about VITA is this is not it's certainly not a wellness vendor. It is, and it's not an external sort of review of coverage in the traditional sort of insurance way of thinking about that. These, you know, when we talk about medical judgment and second guessing medical judgment, we're actually putting these decisions in the hands of medical experts who have specific training in weight loss management. So, look, I think, as Andrew noted, it's important for us that we set this up in such a way that the medical experts at VITA can coordinate closely with a member's treating physician, whether it's their primary care or an endocrinologist or other specialist. But it's not that we have kind of an external vendor with no experience. They were hiring a vendor that has that experience and very likely has a great deal more experience than their primary care physician. So, look, this is it's team-based care. We're hoping that we can craft this in such a way that it really delivers on that promise. And it's not unusual at all in healthcare to have a specialist consult with a primary care physician, and that's what this is. It's physicians working with physicians and other clinicians to craft the right sort of comprehensive plan to support our members. So just say that to your kind of first 2 points. Lowering the cost of drugs, you know, we would not be here discussing this if the pricing of these drugs wasn't so astronomically high and indefensibly high. We talked about that a little bit in the September meeting, that in order for them to have a value-based, like meet value-based benchmarks, their prices should be coming down between 30 and 80%. Those are, that is driven by the way this market is regulated and largely at the federal level. Do we have some tools at the GIC that can help us perhaps lower the unit cost of these drugs? Yes, and we are pursuing those. That's going to take a little bit more time for us to do that. But there are some intriguing options that we will be exploring. But thank you for the questions, Jane.
All right. Eileen, you are up next.
Thank you. Anna, were you before me, though?
Go ahead, Eileen. I'm keeping track.
Okay, all right. I was just curious how VITA will interact with our PBM and with the health plans, like coordinating the care.
Well, for the people, I may ask others on the team to speak on the health plan aspect of this. But in terms of CVS, the PBM, as I noted at the outset, one of the benefits of this program, particularly with our desire to move expeditiously here, maximize our savings, is that they're already well integrated with the processes at CVS. I think the details of how CVS will work as part of this solution are ones that we'll be exploring through implementation. It's not simply us working in a silo with CVS on one hand and Vita on the other. This will be a joint effort that will include all the applicable vendors. The formulary does not change. We're not changing the formulary here. So the formulary that was put in place by CVS last July that prefers Wegovy over Zepbound while preserving a path when it's appropriate back to Zepbound, those will remain in place. Now, I will say, that just one caveat to that, which is that this is a very dynamic market among drug manufacturers. So it may well be that other manufacturers jump in, seeing the profits that are generated by the two incumbents. Maybe they're more effective, maybe they're less effective. From a plan sponsor's perspective, that gives me options to get the maximum value. At the same time, as Jane noted, we always remember, and we've thought about this a lot through the last several months, can't lose sight of the member experience here, where you had a member in the spring who may have been prescribed Zepbound. In July, the formulary changes and they have to go on Wegovy. And that is not like, it's not simply like, oh, change the drug and you have the same experience. We know that that's not the case, and it is disruptive to our members. They may face side effects. It might not work, and they may find themselves back on Zepbound. And then here we're implementing a new program 6 months later, which will alter that member experience further. So, none of these solutions is perfect. Doing nothing, not an option, really. So we balance the opportunities for savings and efficiency with the impact on our members. Hope that's helpful.
Thank you.
Thanks, Eileen.
Yeah, so Chobi was next.
Okay, a couple questions, Matt. One is how many members, GIC members, are getting a GLP-1 prescription for weight loss?
So the last number we have was about 17,000 of our members. That's likely increased since the last time we looked at it, but that's a good ballpark figure. Somewhere between 17 and 18,000. Yeah.
Yeah, 17. That's fine. And what is Vita saying? Once you implement this program, what's the drop off?
The expected drop off of utilization?
Yeah. I mean, people that just say, I'm not going through this program, I'll just do something else.
I think I'll have to defer to either Andrew or Jeff Levenshires if they have that data handy.
I mean, that's where the savings are.
Right. I would hope, Toby, you make a good question, but it's really about accountability and saving money. So I didn't think the way Matt and team described it, that there was an option to still get a GLP-1 without.
No, I understand that. That's what I understand. Yeah.
Yeah.
No, all the programs that we looked at, all four of them, were in the range of 30 to 40%. The expectation could be as high as 50%.
Okay. Yep, and that's good. Thank you, Andrew. The next question is, when you did your reference checks, like what were kind of when you kind of put it all together, they said, when they went from kind of more of a situation like we have into the Vita program, like what were the key issues? What were the problems? What were the things that they overcame it?
I might have to defer to Jeff on some of this, but this wasn't a procurement where we had reference checks of that type where we interviewed him. We looked at whether or not each vendor was in business, was providing their program to large employers.
Yeah.
Like Northrop Grumman, Vita, and Cisco. Prudential were some of the clients that Vita had.
Yeah, and I wasn't thinking about it from a procurement standpoint. I was just
Yeah.
thinking about it when you're
And-
making, when you're signing a contract, generally people check, they
Right,
get a hold of somebody
right.
who works with them and says, what do you think?
We did talk to WTW, who have other clients who
Yep.
have used these various programs, and asked them for their feedback, which was relatively positive with this. But that's as deep as we were able to go in the period of time we had to
Okay.
explore this.
And then my last question just is, you've got from now, which is, we're almost like 2 months to your January 1st. There's a heck of a lot of communication and implementation to go on between now and then. So I hope Vita's done that before.
Yes, we have right from the get-go, we've had a implementation plan. It's in the contract.
Yep.
I started questioning them about thinking through the process of the communications with the plans, with their providers, what kind of data they would need. We've gotten data sets from them already,
Yep.
and taken a look at it. We haven't had a kickoff meeting yet, but all this is on the table for like the first meeting. We also have a detailed
You signed the
communication
contract last
plan
week? Was the contract signed last week?
this
Something
week.
like that, Andrew?
Yeah, we had to have it signed by this week, earlier this week, to be able to implement in time for
Yeah.
January 1st.
Okay.
I
Thank
will
you.
just note on that last point, just real kudos to Andrew and the legal team. A tremendous amount of work on this contract to make sure that we structured it appropriately. Andrew's already mentioned the data analytics and strategy team. That's spent a great deal of time on the PGs. This has been an all hands on deck effort for us. So I just wanted to acknowledge the
their
team
work
stuff.
just started.
Yeah, the
Oh,
work.
yes, I'm sure that is true.
Right. The hard
It's
work
a huge
starts
transition in
now.
a short period of time.
It's implementation, it's communication, and to the degree our board members here have constituents, I'd love to get their help and support to pull it through. It would be super to have that, Bobby and Kristen and Martin and others. All right, let's keep moving, or we're gonna run out of time. Anna, I think you were next. Go ahead.
Hi, everyone. So I just had two comments. Thanks for this presentation. I just wanted to first sort of support Catherine's comment about evaluating the experience on the program. I'm so glad to hear about all the effort that was done to put that into the contract already, and I am happy to engage with the staff on this along the way and be involved. So whether it's Lauren or Margaret or Andrew, or whoever, please reach out, because I think that's super important to learn from this. And then the second question I had was, often I think programs like this have an exception process, and I just didn't hear anything about that. And I wondered if there was one and how it works.
Yeah, I have to defer to Andrew and or Jeff on that one.
At a high level, I'm not based on, I'm not an expert in this area. Based on my familiarity with going through the process of the interviews and the contracting, there is no exception process. If you want the GLP-1 drug, you have to go and engage with Vita. And if they'll continue to do weight management regardless, and look for the appropriate other alternatives if that isn't the right choice clinically. But this is a single provider.
Right. I think that's the key to remember here is, we think of exception processes and appeals processes. Those are really insurance and coverage determinations around medical necessity. They really don't have the same application to a provider's development of the treatment plan and their prescribing practices that are part of that.
Okay, great. And everyone is involved, right? Both the state employees and the
Yes,
municipalities.
this is all GIC active members.
All GIC back. Okay, great. Thanks.
Over the age of 18.
Right.
Yeah. Hey, Kristen, nice to see your hand up. You can go next.
How much is this going to cost the members? How much is there going to be a cost associated with the enrollment with VITA? Like, are they going to have to pay monthly or anything like that?
No, those are costs that are VITA is paid exclusively through the GIC and the fees that we pay them. So there's no additional cost to the member. The only applicable cost here would be, the applicable cost sharing that goes along with any drugs that they're prescribed. So if it's a GLP-1, they'll get the copay.
Perfect. Thank you.
Yep.
I'm going to go to Dean and then I'll go to you, Bobby, if that's okay. Go ahead, Dean.
I'd be interested in just seeing the contract if that's allowed. I wanted to ask this question that if educators ask about the rationale of this change, and I need to explain to MTA where the savings is realized. How do I address that? Is it simply the expectation that fewer people will participate? And I'm not asking that as a got you question, by the way. I'm legitimately just wanting to be clear about where the savings is realized. And then the other question, I guess, is just a broader question: is what more can the commission do to address the larger problem? This could offer a short-term solution, but long-term, we're looking at continuing inflationary pressures and the fact that these drugs are just totally absurdly overpriced. And I'm curious to know what tools we have to address that and how we could think about maybe approaches that go beyond the work of the commission per se in addressing that. The weight loss is one outcome, but these drugs are increasingly being shown to improve all sorts of metabolic disorders. So going in the direction of reducing access seems to me, deeply problematic in a whole lot of ways. So that's what I wanted to say.
Yeah. And
you, Commissioner, a couple of thoughts on that. Number one, happy to send the contract. I don't know if you will glean from the contract sort of the answer in a crisp fashion in the contract that you're asking about where the savings is. But look, we've mentioned this a few times, and I think it's worth just zeroing in on that the savings accrued here is by fewer members taking GLP-1 drugs than they do today, right? And what our strategy here has been is to ensure that those who most need the drug and those who are willing to do all that it takes beyond the drug to achieve and maintain weight loss will maintain access to the drug. Given their enormous expense based on their price, as you correctly note, our obligation as a plan is to make sure that we, and not in a financial sense, but we get a return on the investment in these drugs, right? So the FDA approval criteria and all the clinical evidence supporting GLP-1s says that the drug alone, without changes in diet and nutrition and regular exercise, it's not sufficient, right? It needs to be part of a comprehensive plan. The drug is helpful, but it's not a magic pill. In order to achieve and maintain weight loss, there are a number of other elements that need to be put in place. And this is our effort to make sure that that is the case. I will say, the other savings that we get sort of is derived from that strategy, which is when we're investing in these drugs and need them to be successful as part of a big comprehensive treatment plan, that should lead to more sustained weight loss on the part of our members. That will improve their health and wellness and well-being. That will therefore, over time, produce savings to the GIC. We're unique in some respects as a plan sponsor because we have members who are with us for so long, which is unusual in the insurance market. So we're well positioned to benefit in the long run from a savings and wellness perspective from this type of an intervention.
We need to keep moving, Matt. We're going to run out of time. So, I do just want to summarize, Matt, though. It's appropriate use for appropriate patients. And that's what we always want to do in healthcare when we have limited resources. So I don't think anyone here is saying that, any patient who needs it, wink, wink, we're going to try to restrict it. It's accountability, engagement, and appropriateness in order to deliver better outcomes for our constituents. And sometimes you need a coordinated, focused approach. And to me, that's what VITA provides. So, Bobby, I see you have your hand up again. So go ahead and take the floor.
Thank you. So I'm very curious about, I think that we're talking about adults over the age of 18. So I'm particularly curious about that, 18 to 26 age demographic who are still covered, right? These are the children who are still covered under their parents' health insurance, and if there are any, if there's any data on the drop-off, because the expected drop-off rate's pretty high, right? And I'm particularly curious about the drop-off rate for that demographic, because these are, adults legally. However, they're still children covered under their parents' health insurance. So I'm curious if there are any statistics about the drop-off rate in that demographic, 18 to 26. And also, I would like to know how is this going to be messaged to the members, and does VITA have any experience with other public sector health plans, public sector employees? Do they have experience in other states? Or is it strictly, with private employers? And how are we messaging this in literally like less than, 3 months to our members? Will it be through the coordinators? Will there be emails? Are there going to be any, information sessions like we do in January? Like, how is this going, to be messaged to our members? Anyway, those are my questions. And I
Well,
just want to say, I appreciate GIC's effort to sort of rein in expenses, but it's a very high drop-off rate. And it is concerning because we know, at least those of us in the public sector representing our members know, you know, that it's a lot for people to do. I understand the reasoning behind it, but I just want to comment that it's a lot of time and effort that people may not have. So,
yeah. Let me take a few of those questions, Bobby. In terms of messaging, as I mentioned earlier in the slide deck, one important element of this is direct outreach to the 17,000 or so members who are on GLP-1s today, right? So there'll be an intensive effort on the part of VITA to get them enrolled. Again, they're paid by participating member. Their fees are directly linked to high engagement in the program, which is what we want. The rest of the communications plan, we're happy to provide some more detail as we move forward through implementation. Those details will get fleshed out. As Andrew said, there's already some elements in the contract, but we're happy to share more about that. But look, we acknowledge that it's unusual, right, that we would implement this type of a program mid-year. And so we're going to take the extra efforts to, with all of our tools to make sure that folks are aware that this is coming. In terms of their experience with other state employee health plans, I can't speak directly to that. Maybe Andrew or Jeff can do that, but I can say that in my engagements with my colleagues at other state employee health plans, there's only a small number, very small number, that have proceeded. I don't know what the number is, but my sense is there's very few of them that have gone down the route of implementing a program like this yet, but there is a high degree of interest in doing so. I was, because of where we are on this topic, I was asked to present in a webinar sponsored by the Public Sector Healthcare Roundtable, which is me and my peers across the state, also kind of large municipalities and counties. And I got lots of questions, and folks are very eager to see how this goes for us. And I would be very surprised if those states that continue to cover GLP-1s don't implement these sorts of programs to try to manage the cost. On the 18 to 26-year-olds, I think that's something we're going to have to take back. I don't suspect anyone here handy has any specific information on that age group, but we're happy to take that back.
Yeah. And Bobby, I just want to let you know, having worked with the staff throughout the summer on this issue, the team really wants to keep access to these life-saving and life-enhancing drugs, as many of the commissioners have mentioned. I think Jane spoke eloquently about how GLP-1s can save lives, the data on staving off diabetes, which disproportionately affects, groups of color, and just in general, these drugs are meaningful for health. At the same time, we're trying to balance the cost. The state is under enormous pressure, and ANF, along with the governor's office, is concerned. So we are trying to balance that, and this program has good results. It's supported by by CVS, and we're going to track it as Anna has suggested, and so too has Catherine, because we all want to see the data to make sure it works. So these questions are excellent, and we appreciate all of them. It's good to have such engagement with our commissioners. So I see, Dean, you have your hand up again. Go ahead, please. You have the floor. I think you need to unmute yourself.
GIC is operating under these fiscal constraints that are determined through the political process. I was wondering what would need to happen so that we could be clearer about the price structure of these drugs. I haven't followed this closely, but I know that Costco will be offering, I think it's Ozempic, I can't remember now, and I believe it's $500 a month. I'd be really curious to know how those prices are set and how we could ensure that the prices that we get are at or below kind of the prevailing best practices in the healthcare market. And again, I'm saying this naively. I realize that in a way is beyond the purview of the GIC, but it just seems that we're going to be addressing this one way or the other going forward. And so if there's a way to touch that information, I think it would help our discussion going forward.
Yeah, I appreciate that question and comment, Dean, and I think you're spot on. It is the pricing of these drugs that creates the problem that we struggle with today. As I think I've said before, if we didn't have the pricing at such really just astronomical levels, we would all be simply celebrating these drugs and wanting to get them as easily as we could to everyone that needs them. And the tools available at the state policy level are very limited because the prescription drug market is such a national market. Some states are innovating. They're creating prescription drug affordability boards and setting maximum allowable prices for drugs. Those are being challenged in the courts left and right, so none of those have actually moved towards implementation. I do think the state has made some progress in this area generally around prescription drugs, where the Health Policy Commission has been given some new authority recently to really delve into these cost pressures and bring CEOs to hearings and have them sworn in under oath and that sort of thing. My hope over time is that will yield some countervailing pressure on prices, but those things take time and are very uncertain. I will say I was just recently invited to be on the panel at the Health Policy Commission's annual cost trends hearing, and specifically on the topic of prescription drugs. So that will be a platform. And I can tell you, we regularly, on behalf of this agency, engage with leaders in the legislature on this very topic. I mentioned earlier the Public Sector Healthcare Roundtable based in Washington, D.C. One of the things that they're especially good at is federal advocacy on these topics. I will be very involved in that, advocating at the national level for policy changes. But these are, you rightly point out that we do our best in our narrow, if still significant, slice of the market here. But these are much larger policy decisions, sometimes decisions of omission, of action that really put us in a bind, and frankly put everyone that purchases insurance in a bind. So I appreciate that comment. I do, as you mentioned earlier too, what can the commission do? I will do everything I can in my role. It would be interesting to contemplate future commission discussions where we can organize ourselves to speak as an agency and a collective of commissioners to call on federal and in some cases state policymakers to take specific actions, because so much of what we struggle with today is outside of our control. I really appreciate the comment, Dean. Thank you.
Can I add something, Matt? Just specifically on our arrangement with CVS recently indicated that we might see some price lowering going into the new year based on the new formulary and changes in the utilization management criteria required by the manufacturers. One thing to keep in mind is the direct-to-consumer pricing by pharma on these drugs is really based on the fact there's no controls. So they're often lower than what we've been paying, but my understanding is we should be getting below that number going into the new year.
That's good news. Thank you. Well, this is really good discussion. Again, I thank commissioners for your engagement. I think the staff enjoys these meetings when we have a plethora of differences brought forward. That's what strengthens our commission here. So thank you all. It sounded like there's serious concerns about implementation. So to the degree that you can start getting into the weeds, making sure you engage all of our constituents as aggressively as possible, supporting members. I see you nodding, Andrew, so I know you've taken the lead on this. A sense of urgency in making sure this is rolled out well. This will reflect well on the commission if we can and when we show savings from this program, but also still providing access to life-saving medications. So thank you all for this discussion. I know we have one more way to save some money here. You got some time to walk us through it, Matt, still?
We do. I'll be brief on this one. In addition to the Vita solution, which, as I said, we project will produce 15 million in savings and 30 million annualized going forward. We are also implementing a program through CVS called Drug Savings Review. So just to note at the outset, this is not specific to GLP-1s, but is a broader effort on the part of CVS. We will also be implementing this on January 1st. This program essentially runs in the background in a way as an additional clinical review that engages with a prescriber of a high-cost drug for in instances where there are less expensive alternatives that would also be clinically indicated for the member, and encourages the prescribing of the alternative drug. The member, the prescribing clinician still has the ultimate say on the prescribing, of course, right? So this is it's a relatively light touch, but it is a thing that we can do. It's a step that we can take. CVS will be monitoring our pharmacy claims over time and looking for opportunities to intervene in this way. There is, the only impact to the member from these is that the prescriber may, in his clinical judgment, based on that engagement with CVS, change the prescribing to a different drug. So we're leaving that fully in the hands of the prescriber. These, in addition to cost savings, these recommendations should lead to and can lead to more effective and evidence-based prescribing of particular drugs. So a variety of different impacts here. Again, I'll note on the bottom right that we do have performance guarantees that are embedded here with CVS that give us confidence that the savings that they are projecting are savings that we can realize. So that's the drug savings review. That's a program that we're already implementing on the EGWIP Medicare side of the shop, and that's been in place for almost 10 years. So here we expect an additional 10 million in annualized savings, so 5 million for the remainder of fiscal year 26.
Hey, Bobby, I see you have your hand up. Go ahead.
Sorry. Thank you, Valerie. So I just want to make sure it's exclusive of the GLP-1s, right? These are other medications.
I don't know if it includes or excludes it, but it is not focused on GLP-1s. It may well include GLP-1s, but we don't have. Well, actually, I can't see how it would affect GLP-1s because we only have on the formulary Wegovy, and then through the exception. So I don't see that this would apply to GLP-1s, but it's really designed to be much broader.
Is there a list of like medications that are going to be like reviewed?
There is not a predetermined list of drugs to be reviewed. Andrew, can you help me with that? We did have some information about how they.
Yeah, it's not on a like targeted drug. It's looking at conditions. It's looking at for drug interactions. So you may be on 5 or 6 drugs. They may note that there's negative interactions between some of these, or there may be better choices if you're taking X to have Y. All those kind of things. Targets the proper use of low molecular weight heparins. It's looking at opioids in combinations with other drugs. It's that kind of thing. We had a similar program with ESI. It's nothing. We didn't really talk about it back then. It was built into the plan. It's nothing the member will be even aware of because it's not member facing at all. This is through their communication channels with the prescribers, and that's where the back and forth is.
Okay, so in other words, CVS is going to reach out to the provider directly, the prescribing provider directly to see because right now, right, generics, right, if there's a generic available, let's say, so if someone is already on a generic, does that mean there might be a less expensive generic that like
we have
like
generic preferred, is a state law to start with, and then it's built into the contract. So in order for someone to avoid a generic where it's available, they have to go through a PA process. Anyway, that's not the focus of this. It's there's a lot of medications within a class. There's more than one option to treat things.
Right.
A PCP may not, is not an expert always in the variances between the various medications. So they're looking for opportunities.
Okay. All right. And what has been the like savings on the EGWEP since that's been in place for some time? Do you have any idea what the savings has been for that group?
Off the top of my head, I do not know. I know that CVS claims they could save as much as $40 million with our plan. I'll believe it when I see it.
That would be great. That would be great. I just want to say that I appreciate all the efforts because we know that this problem is bigger than all of us, and it's a very serious problem that we're facing, from a budgetary perspective. And so I do appreciate, although, there are concerns, obviously, this is something new and different. I do appreciate the efforts that you're making, that, and, GIC staff looking into ways that, will save money and also continue to provide people with the medications that they need. So I just want to say that, even though I have concerns because we don't know how this is going to play out, but thank you for all the hard work looking into, what could be a really good solution.
Thank you for that, Madam Vice Chair. With that, I think we move to the final slide and the final piece of the presentation, which is just about next steps. I hope that what you can see is that we've attempted to find a middle ground here with very limited options that are available to us to act mid-year. But doing nothing would risk that we just do not manage to our budget, which is our obligation. And since we did not have that necessary authority from the legislature yet to do as she's asked, we've tried to find a series of steps that we can take. 20 million in savings combined. It's near to the 27.5 million of the veto for GLP-1s. Our hope is that will surpass our the estimated savings that we have here. We also still have the formulary change that was instituted in July that should produce savings. We'll be monitoring our claims and finances to see how that plays out. So that's what we've tried to do here. So in terms of next steps, we've, as Andrew noted, with both of these initiatives, we'll be moving forward with implementation ASAP with both VITA and with CVS Health. We will, of course, continue to monitor any developments in the legislature about the GIC's budget and evaluate FY27 plan design options. We will be very quickly, as all of you know, moving towards those discussions, getting ready for our coming fiscal year, and so we will be back with you to prompt those discussions in the coming months. So that concludes our presentation for the day. I really appreciate the level of engagement in this discussion. It's really helpful to us. And your, just continued encouragement and support of the staff as we tackle these many challenging problems.
Yeah. Well, thanks, Matt. I don't see, Toby, I see your hand up, so good. Go ahead.
I was just curious how the results look through September, or in terms of the financials. We're gonna take a look at that chart, or is that not?
Yeah, we don't have a CFO report for you today, as Jennifer is getting her feet on the ground. We do typically not have an October meeting. This one we wanted to make sure that we circled back with you on. So as Jennifer gets her feet on the ground as our CFO, also wanted to give her a little bit of time to pull that together. So we will be back in November with our year-to-date financial.
What's your sense? Are we still tracking off the budget, the trajectory, or just kind of a gut, just a ballpark gut?
I hesitate to even say that, Toby. I'm a data guy, so I want to see the
Okay.
numbers.
Okay, okay, thank you.
Yeah.
All right. Well, thank you, everyone, for being part of this engaged discussion. I know the staff has taken copious notes on commissioners' questions, especially concern on implementation, pull-through, execution, a plan. And I don't think it came out specifically. However, there's still more to be done. I think each commissioner feels that we're not there yet. And so, it's like this great idea, need to see the execution, need to see the results. And then what else are we doing to stave the growth and still support our constituents? So, thank you, everyone. We will see you in November. At this point, it's all hands on deck for implementation, and Bobby and others who represent constituents. I know Dean is already thinking about questions he might get from MTA. We'd really love your support and continued guidance to have your constituents buy in, support it, and all be part of the solution. So we'll see you in November. Enjoy this beautiful day. Looks like we're going to get some decent fall weather through the weekend, and I wish you a good day. Bye,
Need a
everyone.
motion to adjourn.
Oh, I need a motion to adjourn. I got caught up on the beautiful weather here. Motion to adjourn.
So moved.
All in favor? We all just say
Aye,
aye. And I heard
Aye.
Toby second it too.
sure.
We're all good, Andrew. Bye, everyone.
Thank you.
You get
Bye.
10
Thank you.
extra minutes now.
Mhm.
Thank you.
Thank you. Thanks, Matt.